Hi, I'm Dr Nick Dunn, and I had a lot of experience in Scotland as a general practitioner in a practice, as well as being a lead in some of the clinical services for out of hours and postgraduate GP training. And during that time, one of my big passions was trying to help people understand better how their bodies worked and some of the medical issues that arise with them, particularly people who are not part of the medical world. So this podcast, Doctors Decoded, the whole aim of this is to try and simplify some of the issues that are current and help people understand a bit more about the issues that are affecting their bodies. In addition to that, it's a great opportunity to meet some people who are specialists in their field and get to understand what they do, but also how they tick as doctors and get behind the scenes and understand what motivates them as doctors and maybe what they do out with work, which keeps them going. So in this episode, we're going to talk about overweight and obesity and some of the issues around that. So we know that in Guernsey, around about 57% of people in Guernsey are overweight or obese. And in the UK, the numbers are even higher, around about two-thirds. We've known for many years that overweight and obesity are issues which actually impact quite significantly in our health. And they contribute to issues such as diabetes or osteoarthritis or ischemic heart disease and even depression. And we've grappled as a medical community for decades to try and find ways to address this. And there have been many, many projects to try and encourage people to eat less, exercise more. But over the years, we've discovered that it's actually much more complex than that. And as we delve into the science behind obesity, we know that there are hormonal factors, there are genetic factors, there are factors which even we don't even be aware of as children that might be affecting us as we grow up. So what we're going to look at today is these new drugs that are available, the injectable weight loss drugs. And more recently, we now know that there's a weight loss drug that's available to be taken as an oral pill. And although that's not been approved by the NHS, it is available privately, and it might be a game changer. So what we're going to do today is speak to Sally, who is a specialist GP who runs a weight loss clinic in Guernsey, and find out a bit more about her experiences over the past few years. So welcome, Sally. Nice to see you.
Nice to see you.
And you've been working as a GP in Guernsey for about, 3 or 4 years now?
6.5 years now.
Oh, longer than that,
Yes,
goodness.
exactly. Had 2 kids during that time, so it probably is more like 3.5 or 4 years.
Yeah.
Yeah.
And tell me a bit about what was it that made you decide to study medicine?
So it's quite boring, actually. Both of my parents are doctors. My dad is a surgeon and my mum's a GP. So I could quite clearly see how it was being a doctor growing up.
Mm-hmm.
My dad did a lot more shift work and my mum was kind of there for school pickups and things. But I absolutely loved science and I love talking to people. I love finding out what makes people tick. And so medicine just actually, unfortunately, was quite an easy career choice. There's no excitement there.
That's interesting.
Really.
But there was no pressure for you to do that. It was your own choice.
My husband actually asked me the other day, did you consider anything else? And I just was like, no. And I realised how crazy that is now. But I think that's probably the way with some people who have doctors as parents and for people who don't. Some people probably just want to be doctors and but I love it. It's great.
No, it is a great job. Something I've really enjoyed about medicine is the variety it brings. And I think it's quite a forgiving career. I mean, I started off in anaesthetics and intensive care. I did that for 5 years. And the switch from doing that to GP training was actually quite seamless, to be honest with you. So I don't know if there's many other careers where you can make that kind of switch so dramatically.
Yeah, there's something for everyone.
Yeah.
I did 5 years in A&E. I really enjoyed that. But the training was about 13 years that I would be stuck in kind of one place or rotating around. And it was going to be too difficult. I wanted to have a family.
And
what
was it? What was it you enjoyed about A&E? What was it?
I think it's just that I am a problem solver. I love to kind of yes or no, sort it, whatever. So it was just kind of like you sort the problem and it's done. I guess GP is actually the opposite, really, because especially in Guernsey, we are kind of, we're almost in a patient's extended family here. We take responsibility for our patients. They wait sometimes to see us. I really love the trust that's here, the relationships that we build together. And the way that kind of in Guernsey, seeing the same people, often 5 generations of a family, you can understand more of the whole picture. So you can often kind of practice holistically much easier than elsewhere. I was working in London and it was kind of 10-minute NHS appointments, bam, bam, bam. I never saw the same patient twice. And it was quite tricky, you know. I've got a sore elbow. Okay, why is the elbow sore? Let's mend that. Whereas here it's like, okay, you've got a sore elbow. Okay, well, why has that happened? How is that affecting your life? What else is going on? Are you not able to rest because of the sore elbow? Is that spilling over into any other areas of the life? How is your daughter dealing with your sore elbow? I know you guys do this together. You know, it's just, it's a completely different ball game here in Guernsey. And I'm not saying that that is the case for all of the UK, but it was just the kind of intercity, you know, urban area I was working before.
And it's interesting because I sometimes think when I've spoken to trainees who are in hospital doing the more acute jobs like A&E or anaesthetics and ICU, for them, I think the thought of that continuity is quite daunting. I think they think, gosh, that must be quite hard because how do you deal with people keep coming back to you? But like you say, that's what makes it really satisfying, I find, and especially after me, I've been a GP now for about over 20 years, and it's actually one of the things that keeps me interested in the job, actually, is that continuity. And you did a bit more than just A&E though, didn't you? You've done some other interesting things.
Yes, I have. So my husband is a lawyer and he's an offshore lawyer. We ended up moving to the British Virgin Islands for a while, for a couple of years. And I was a registrar in the hospital for A&E. And then I also covered some of the private islands in my spare time. So a few of the private islands around the British Virgin Islands, I'm sure you can tell what I'm talking about. But needless to say, I had a fabulous time and everyone was really, really good fun, very kind. And yeah, it was an amazing life out there.
And you're not going to tell us who your patient was, the famous patient?
No, I won't. You can guess. He's a sir.
There's something in the name of the islands, I think, that might
possibly, indeed, yeah.
So you came to Guernsey and you've obviously been enjoying general practice, and it sounds like you really enjoy all aspects of the job, actually. But recently you've had this opportunity to work with the weight loss drugs. Tell me a bit about how that all evolved.
So I think, as you know, this is a huge area now, but it kind of came into play a couple of years ago, 2-3 years ago, and we kind of flagged it quite early as something that would be really useful for Guernsey as a whole. As you say, 57% of adults here are overweight or obese, and that's quite startling numbers. The WHO have just recognised obesity as a disease, so that means it's on a par now with asthma, you know, type 2 diabetes. And so I think...
and just to clarify, that WHO is the World Health Organization?
That's it, exactly. So now doctors are kind of recognising that it's a massive area that we need to understand more about. It's not just one area, it underpins our lives as a whole, really. So I had quite a lot of patients who had put on excess weight that they didn't want. They didn't feel comfortable in their skin anymore, even though some of them look fantastic. Sometimes if you're overweight and you're carrying excess weight that you don't want, you just know it. And I guess the particular categories that kind of I was able to relate to would be the young mothers or people, even kind of more mature mothers who are kind of juggling so much, you know, childcare, pickups, clubs, you know, at work maybe in some cases, and just don't have time to kind of eat healthily, don't have time to exercise.
And often they don't have time for self-care at all. They're so busy looking after everyone else. And it's interesting, that whole idea of describing obesity as a disease, because I think for a long time we have thought of it as a bit of a cosmetic issue, really, hasn't it, and how people look. Whereas thinking about it as a disease process is quite important, isn't it? Just to reclassify
very
that.
Much so. So I think that, well, the word fat in my office is banned. That's done. I think that whole ethos of judgment on someone's weight is and should be over. I think we need to understand that people who are carrying more weight than they like, it's not due to, you know, them eating the wrong things or eating too much. In a lot of cases, somebody can actually have a perfect, what we would call perfect diet, perfect kind of energetic kind of active lifestyle and still be heavier than they would like. We know, as you said in your introduction, it's hormones, it's genetics, it's environmental factors, it's psychology. I mean, to go back to the group that I mentioned, there are a lot of triggers there for young mums and indeed anybody to hear food noise. That's something that has now entered our ethos of this food noise,
Tell me
quote unquote.
what is that? I mean, I've obviously, it's something I'm familiar with that term, but because I'm not dealing with this particular issue quite as much as you are, what do people mean by food noise?
So food noise would just be kind of like, as you're going about your day, thoughts of eating, thoughts of cravings, thoughts of, I guess, shame with food. Everything that kind of underpins us, you know, we'll be walking along the street, oh, there's that cafe, like, oh my gosh, do I have time to get a croissant on this? You know, that would be a food noise. Or
Right.
I'm so tired today, I just need to have X to make it through. So the food noise might be heard by some people if they're tired. They might hear food noise if they're stressed. They might hear food noise if they're bored. Like a typical example is you're sitting of an evening watching telly and you're going backwards and forwards to the fridge or to the cupboard. You might hear something out of habit. Whenever you go to get petrol, you pick up a Twix. And the food noise, we all do need food noise. Our body does and our brain does need to tell us when we're hungry. And of course, we need to be looking for the right things. Do we need carbohydrates for energy? Do we need protein for our muscles? What is it that we need? So food noise can be very good, but often it's being used to kind of describe when it's becoming overwhelming for people. They're hearing it all day. It's been very satisfying and really interesting in the weight management clinic that I run to hear that a lot of people's mental health has completely changed because actually they have been hearing food noise all day and it's exhausting for them. It's almost like someone on the back going like this, just tapping you constantly, and that's been taken away. And some people have come in and burst into tears and just been like, the food noise is gone, thank God. So that's been really lovely.
Yeah, it's interesting you talking about that food noise because it makes me think about, is there an addiction element to this? You know, is there such a thing as food addiction in the same way that we get alcohol addiction or drug addiction or gambling addiction? Is there anything in that at all?
Absolutely. So, I mean, we know that there can be, so when you eat something, so your body releases ghrelin, which makes you feel hungry. And that's all very good. And then there are two mechanisms by which it should stop. So the first is the GLP-1 mechanism, the glucagon-like peptide one, and that is released from the gut in response to food, and that triggers us to feel like we've taken enough in, we're not hungry anymore. The second is the leptin pathway, and that leptin pathway is triggered by fat cells. So usually if we get we get a healthy amount of fat cells, they secrete leptin and it tells us stop eating. We've got enough in reserve, we don't need any more. But what can happen is where the fat cells are that much bigger for that much longer. So somebody who may be battling with their with their weight for years and years, that leptin pathway gets broken. And so the body is not being triggered by the leptin. The leptin goes to the brain and it doesn't cross over the blood-brain barrier. And so then the body thinks it's starving and then you start trying to eat more and more and more. So there is definitely an addiction in that if you have bigger fat cells, so you're more overweight, you want to eat more and more and more.
Right.
And then obviously there's kind of the sugary carbs addiction pathway. You eat some sugar, your liver basically makes you want to eat more. You kind of dump sugar and then you're locked in it. So yeah, there are addiction pathways, and it's
almost a vicious cycle that people get into.
Massively.
Right, I see.
Massively.
And it's interesting. I was reading recently that they were describing fat as an organ. You know, we think of fat as being individual cells and not really very intelligent and not doing very much, but actually they reckon that there's something about fat that communicates between fat cells communicating with each other, and that there's a bit of a memory there. So some people struggle if they've been overweight when they've been younger, then they lose weight, but there's still this drive to gain weight again that's intrinsic in the body. And I think it's incredible how complex the whole system is, isn't it?
It is really interesting. And I think the thing to remember is, well, something that's been interesting is that when we remove that kind of food noise and the psychology of needing to eat
Yeah.
and being locked in the cycle. So say, for example, somebody was on a weight loss injectable and that's gone. It's really important to put the work in to kind of identify what was it that my body or my brain was wanting me to do before that led me to be bigger than I would like, and how can I stop that?
Yeah.
Like, you know, you go to get the petrol from the petrol station and you see the Twix. What are you going to do? Are you going to say, "Oh, I'm on a weight loss injectable, I'm not going to eat that"? I don't think that's the answer. The right thing to do is to be like, I'm going to grab I've got some water in the car, or I'm going to grab an apple instead,
Yeah.
and just retrain so that if you did want to come off the weight loss injectable in the future, then those kind of areas are there to catch you.
So we've talked a bit about sort of how these drugs work, and from a practical point of view, you know, how do you assess people? For example, you know, I might see someone who's talked to me about their weight, or I might even discuss it with them. And in fact, that's an area that can be quite sensitive as well, is actually
Yeah.
how do you bring it up in the consultation? Because obviously I try and be very sensitive about it and use open questions, and the person might be in about something to do with their blood pressure, and then it's maybe asking, you know, how's your weight? And some people are very open about it. They'll say, actually, I feel overweight, but I want to do something about it. I'm trying to exercise more, or I'm trying to eat less, or I want to think about maybe some medication for that. But there are some people who often, if I'm honest, women who have really struggled to get their weight off, become very emotional about it, no
Yeah.
matter how hard I try to be sensitive about it. But it's difficult because, on the other hand, I feel I would be remiss not to mention it,
Yeah.
because, like you say, it's a disease. So,
Yeah.
so how do we get around that? What would you say? What would your advice be, I suppose, to other GPs in that regard?
Well, I think times have massively changed, because I feel that it is okay to bring up now, because I'm not just going to be saying to somebody, you know, you're overweight or you're obese. I mean, I would never say that to anyone. But and then that's it, do something about it. Here's Weight Watchers. I mean, I don't know whether this is a good thing or a bad thing, but there is now obviously weight loss injectables, or the tablet that you mentioned. And so people are not kind of left being like, oh my gosh, I'm overweight or I'm obese and it's affecting all of these areas of my health, and there's nothing I can do. I can't manage to do anything about this, and often that would make it worse. So I think it has become much easier to talk about, in that there is actually something that we can suggest and that can help the patient automatically. But yeah, so I think because I'm doing a weight management clinic, they're kind of scattered into my normal day. And so it's very natural for me to bring it up. And then I say, I'm so sorry to mention it. It's just that I'm doing a weight management clinic, and don't think no more of it. There are some people who I can see have got offended, and that might be once a month. But absolutely, sometimes it's worth saying, and I would never mention it out of nowhere. So it might be someone saying, I'm taking 4 tablets now for my blood pressure. Like, is this really my life now? Or like, my knee is so sore, and I've had some steroid injections, and I don't know what to do. I don't want a replacement. And so I would probably pick up on triggers and try to find a way to kind of introduce it based on what the patient had said, rather than just bringing it up out of nowhere. But I would say that people are more receptive to it now. You know, it's all over newspapers, it's all over social media. It's kind of underpinning our generation, I guess, in terms of
And
weight
one of the
management.
techniques that I have found, I suppose I found it quite useful, is using some motivational interviewing techniques, you know, sort of recognising that you don't necessarily come up with a solution in that consultation. And it's about the idea that you might be planting a seed, or like rolling with resistance. So if someone actually doesn't want to talk about it, it's just to accept that and not to probe any further. And then, you know, maybe when they come back, and it's about that sort of longitudinal relationship you have with patients, isn't it? You can give it time, you can plant a seed, and they might come back later and say, actually, I've thought about that. Is there something that you can do to help me? And that's where you get into a really useful conversation about it.
Yeah, it's very interesting, because a lot of my diabetic patients who very clearly would benefit from a weight loss injectable, so not a weight loss injectable, but one of the medications for it, for example, Mounjaro or Ozempic, do not want to take it. And they will not hear anything that I say about the subject. And, you know, they're damaging their bodies with really high sugars. They're on 4 other classes of medication. There's nowhere else to go, and they still will not have it.
And the funding situation with
It
patients
would
with
be
diabetes
free
is
for them.
different.
It would be free for them, so they still don't want it.
So that's one of the advantages at the moment, isn't it, that we have got that funding from the States
Absolutely.
for diabetic patients for
Game
these drugs.
changing, yeah.
And initially, I seem to recall the weight loss injectables were not first line for diabetics, but I understand they are now.
Yeah, so you would usually use metformin first, and then after that, it would completely depend on each patient. But yeah, it can be second line for some people. Yeah, absolutely.
And you've found that even despite the fact they're not paying for it, they're not interested.
Yeah, it's very interesting. I think there is and has been a bit of shame actually about these medications, these injectable medications. Some patients will come to me and say, I've tried everything. I've been on this diet. I've done Atkins. I've done Weight Watchers. I've done a marathon, and I've gone up and down, up and down. I can't shift this weight. And I'm just so ashamed to be here. I feel like this is, you know, a quick fix. I'm cheating. And I say to them, this is going to take work. This is not a quick fix. It's not a cheat. It's going to be amazing. If we do this, there's no shame. It's up to you whether you share it with people, whether you don't. You can say whatever you want. This is your business. And when people come back to see me at the 6 month mark, I don't feel like mostly any of them have shame anymore. They have had to work at it. It's a complete lifestyle change. You know, they've got boosted energy, so they want to exercise. They're feeling lighter, they're feeling happier, they're feeling just much, much better. And they always say, I don't feel ashamed now. I can see that my body needed this. I feel that I suit this. This is my natural weight now. I'm starting to get there. You know, thank goodness for this.
And I suppose the big thing that often people want to find out about at the end of the day, because like I said earlier on, there's a lot of information out there about these weight loss injectables and chat on social media and on media. The big question they will ask is it safe? So presumably you have that conversation at the outset. So what do you see as, you know, the downsides of these drugs?
So I think the downsides are that it can make people feel a bit grotty. So the day you inject and a few days afterwards, you can feel quite nauseated. I have had some patients who've vomited. Diarrhea, constipation, acid reflux, those can happen, probably 1 in 10 maybe. And then uncommonly, the big risk is the risk of pancreatitis, which is 1 in 1 to 2,000. And 1 in 20 times you get pancreatitis, you can die. So that is quite concerning. And I have had some patients turn around at that stage and just be like, do you know what? No. But, I think...
And have you had any occasions where you've had complications with patients?
I haven't actually, but we have had 4 cases of pancreatitis in Guernsey because of weight loss injectable medications. So it's definitely happening. No, I've been quite lucky. We have had a case of gallstones. So if you lose a huge amount of weight quite quickly, regardless of whether you're taking a weight loss injectable or you're lost in a forest, you can get gallstones, you can lose hair, you can lose muscle.
And that's a big thing, isn't it?
It is a big thing.
The loss of muscle mass, and something I'm quite interested in, because obviously I'm getting interested in sports medicine and musculoskeletal medicine and the importance of physical activity and maintaining muscle mass, particularly for people who are in their 50s and beyond. As they're getting older, you tend to lose muscle mass anyway. And trying to encourage people to take part in resistance training routinely, because we all know that, for example, cardiovascular exercise is really good for us, but there's less emphasis on resistance training. And there's been quite a lot of research coming through about that. But for people who are on weight loss injectables, I think that is a risk that they might not be so aware of. Is that a fair comment?
Yeah, definitely. I have had a couple of patients who I didn't start on it come to me having lost muscle. And I suppose this was kind of 2-3 years ago when there wasn't the bigger knowledge base around it that there is now. But yes, some people have been quite disappointed by that. But muscle's greedy. It wants energy. And if there's a calorie deficit, the muscle can be lost. And it's it's tough, but people do need to be really strict with trying to conserve muscle if they go on a weight loss injectable.
And how would they do that? What would you
So
recommend?
absolutely. So resistance training, so Pilates, yoga, even just lifting the shopping and walking with something on their back and making sure that they exercise their legs and their arms. So if you're walking with something on your back, obviously you've got the weight going through your legs, but you need to keep your arms. So even baked beans at dinner, whatever it takes, some gentle weights or whole body weight. So Pilates, yoga, press ups, those sorts of things.
And what about hair loss? Is that something that's being increasingly recognised now?
For sure. So again, it's just nutrient deficient, really. So we always recommend if you were to start any diet, really, you should take a multivitamin. So that will conserve your folate, your vitamins that you need for hair growth. Iron is another big thing. So people just need to make sure that they're taking in enough iron and folate.
And so if someone came along to you to start on treatment, what's the kind of clinic appointment basis like? Just talk me through, how that all works from a system point of view.
So they will kind of tell me a bit about what's led them to be heavier than they would like. Then we'll weigh them. Sometimes they don't want to look, and that's fine. I can then check if they're going to be eligible or not. Then we talk a little bit about their options. If they're only doing it, so if they have diabetes, we would use the gold standard, which is Mounjaro, unless they didn't want to do that, and then Ozempic would be okay. If they don't have diabetes and they were doing it for weight management purely, then it would be Mounjaro versus Wegovy. There is a Wegovy pill now that you've mentioned as well. So then we would talk about the different options. We'd talk about the side effect profile. We would talk about the psychology of eating, so food noise, and then what to eat. So a kind of like protein cannot be stored as fat. So eat as much protein as you like. It's amazing. It fills you up. It helps your muscles, hair, skin and nails. It's great.
And just remind us what protein-based foods are out there.
So the best protein-based foods will be the ones that have low fat in. So that would be lean proteins like chicken, fish, lentils, peas, quinoa, those sorts of things. And then obviously you can get protein that's marbled with fat. So that would be your red meat. So mince, sausage, steak, lamb.
And what about in terms of the long-term treatments with, we've talked about some of the side effects, obviously, and you're mentioning that you get that follow-up with the nurse as well. And my understanding is that they'll obviously try and emphasise some of these psychological elements as they go. It's not just about checking blood pressures and weights. It's actually about that psychological support as well. How long do you tend to see people staying on these drugs for, and could they stay on it forever?
Yeah, so there was a licensing, certainly of one of the injectables for 2 years. That's now dropped away. So there are some thoughts that people may be on these lifelong. I think the statistics are something like 1 in 5 Americans are on them or have been on them in the last 5 years, which is staggering. And I do think that as time goes on, more and more people will probably start to be on them. People may switch from the injectable to the tablet. We'll have to see how it goes. This is obviously a very new area of medicine, so we're quite flexible at the moment. If you meet the criteria to go on a weight loss injectable, you can, in theory, have it for as long as you need. There will be some other bits and bobs that, we need to make sure that are not happening, but unless your BMI drops worryingly, you could have it for decades, is the thought at the moment. But as I say, this is new and things may change. So there are some people who don't want to go on a weight loss injectable because they're worried about coming off it. Some people do want to come off it. And I have had one patient who went on it for 1 month and then completely retrained his brain, lost 4 stone.
Yeah, that's amazing. and it's interesting, isn't it? It's almost like they've made that psychological leap to take action.
Exactly.
And they've really embraced it. I've had one or two people like that as well, where they've started the injection and then think, actually, I don't want to be doing this. And if it's so serious that I need to be injecting myself, then I should really be taking some action. And it's great if people can do that. But like you say, I think it's important that we don't necessarily use these people as a prime example, because they're the exception to the rule. And we don't want to be, I suppose, judgmental about people's behaviours either, because that's a really important part of it all. So Which part of the weight management clinic do you enjoy most? What is it you enjoy most about this?
I think it's when people come in and they're like, I've battled my whole life. My mum's overweight. I've gone through the menopause. I can't lose weight. I'm leading a perfect life. Please help. And I can help. And that is amazing. And then the kind of feedback, 6 months, 12 months, 18 months, 2 years later, this is me. I'm so pleased. I feel so much better. Of course, there are some people who are really tired when they're on it, and there are some people who get side effects and they don't want to stay on it, and that's fine. But I think it's just being able to do something that helps a patient so quickly,
Yeah.
and then selfishly getting the success stories. Like it's really nice. Sometimes as a GP, you could go a morning where you haven't quite resolved anything really, and you're trying to help your patients as best you can, but the patients may feel like they're not yet thriving, they're still surviving, and to see these patients, they're starting to thrive, and it's lovely. I'm very happy
And it is
with
one
it.
of the drugs that we are confident for the majority of the time it seems to work, isn't
Yeah,
it?
absolutely,
Yeah.
it does.
And which part of living in Guernsey do you enjoy most?
Well, I've got sandy toes today, so I think it's just, popping out from the office, going for a swim, taking my kids to the beach. It's just
So it's
life
about being
feels a
near the
bit
sea.
lighter here. Yeah, it's easier,
Right.
and it's obviously smaller, and it's not for everybody. But I certainly find it, I love it here.
Okay. Thanks very much, Sally. That was really interesting to talk to you.
Thank you.
So we'll be talking a bit more about other topics in the next few episodes. We've got another episode coming up to talk about childhood allergy, particularly food allergies. But that was a really interesting topic to talk about the whole issue around obesity, weight management, some of the complex psychological issues that Sally touched upon there, and changing attitudes to how we approach these things. I would say that since I graduated, the approach to these things has been much more gentle and much more collaborative with patients rather than the doctor telling patients what they should do. It's actually about us trying to work with the patients and find a solution. And we also know that although these drugs have got some side effects, they are very effective. And it's opened up that area so that we can approach people or people can approach us to ask about solutions. So thanks again. And we'll catch up with you again some other time.